Gwen Rotterman. I'm the Associate Director for the Center for Health Policy at the University of Missouri, and I just want to thank you all for being a part of this discussion and continuing to stick with us this afternoon on this important topic, the program of Medicaid in Missouri and at the federal level. I first, and I get the distinct pleasure of introducing Melanie Bella to you today. It was several years ago when I was a lobbyist trying to learn all I could about the Medicaid program that I heard Melanie speak down at the Lake of the Ozarks. And I was totally impressed with her, not only with her grasp of the program and its possibilities, but her vision for the future and her ability to take the program, which is so complex, we all know how complex it is, and to translate the program into terms that we can understand, and then the fact that she could sell, her ideas and the possibilities of that program in the state of Indiana to the state legislature is no small feat, and you all need to know that. Indiana's Medicaid, Melanie was the director of the Medicaid program in the state of Indiana, a post she held from 2001 until January of this year. Indiana's Medicaid operating budget was over $4.7 billion, and it serves more than 844,000 recipients. And I know that her enthusiasm and her vision and that ability to talk to us all, no matter where we're at in terms of that program, helped her in her post in Indiana. Currently, Melanie is the Vice President for Policy at the Center for Healthcare Strategies, where she leads the organization's efforts to improve the quality of care for people with chronic illness and disabilities, focusing on chronic disease management, managed long-term care, and special needs health plans for dual-eligible beneficiaries. She's a voting member of the Medicaid Advisory Commission established by the U.S. Department of Health and Human Services. In fact, I understand she's fresh off a meeting with that group and with us today after a meeting there. She also serves as healthcare advisor to the Kennedy School of Government's Innovation in America Government Awards Program. Melanie earned her master's in business administration from Harvard University and her bachelor's degree from DePaul University. Please join me in welcoming Melanie Bella.
Very nice to be here. Up until April, I've lived in Indiana my whole life, and so being in Missouri, I kind of feel like I'm close to home. People smile at me here. I moved to New Jersey. People don't smile so much there. But anyway, it's nice to be here. You've always treated me very well, and I appreciate the opportunity to talk with you. As Gwen said, I'm going to blend a little bit of the work that we did in Indiana on putting together a chronic disease program, but put it in the context of what's going on with some trends nationally in Medicaid in terms of trying to create infrastructures and systems that improve care and hopefully make the program more cost effective as well. And then talk to you a little bit about, at the end, about some of the federal reform efforts that are under discussion and some of the things that we might be able to do, tangible recommendations for making change in Medicaid. These are things that you all know. 50% of Americans are not receiving the care they need. We're seeing an increasing number of complexity in the comorbidities of the population. And I guess what I hear often is we're seeing a growing number of old, and people that are getting disabling conditions older or younger in life. And obviously then that has a lot of implications for the healthcare system. Primary care is changing. Behavioral health is incredibly complex. We all want to improve the way consumers are involved in the system. We have crowd out and crowd in. I think in the early days when we were doing children's healthcare expansion, there was a lot of talk about crowd out. Let's make sure that we're not doing crowd out, giving incentives for people to go on Medicaid. I would argue that now we're seeing crowd in. And with the erosion of the employer health care coverage, that is all coming back onto the public system. Again, the increasing disabilities of the population, the aging of the baby boomers. I think that the aging of the baby boomers is actually less of a challenge right now as it is to figure out what's going on with health care coverage in general. So that's what I'll call crowd in. And then policymakers and purchasers are being forced to look at short-term actions. And then the question for us is, what's the implication of those short-term actions on our ability to have a long-term sustainability for the program? And how do we make sure that the decisions we're making today, under the pressures that we're all under, are actually not costing us more in the long run, both in terms of financially and from a quality of care perspective? So, in the interest of full disclosure, when I came, I had to sign a form that says nobody's giving me any money to be here. But I do have to disclose one thing. I think Medicaid is absolutely the best place to prove that quality can pay. The complexity of the patient population, the amount of money we're spending today on healthcare, to me, presents no better opportunity than within Medicaid. So what you're going to hear today is I'm a believer in investing in quality, and so I'm getting that out on the table right now. So in the answer of this, is Medicaid complete and total chaos in a black hole? I say absolutely not. Medicaid is a tremendous opportunity if we handle those challenges and take those challenges and make them opportunities for ourselves. So big numbers. People are finally starting to pay attention to Medicaid, I think. I'm not sure that people realize Medicaid exceeds Medicare in the number of people served and the number of dollars spent. Now, some funny stuff will change on January 1st when Medicare takes over for the drugs. But think about the opportunity we have if we effectively leverage Medicaid and Medicare as the two largest purchasers of healthcare in the system. And just to spend a minute on that, you'll hear me talk quite a bit today. I'll get on a soapbox about the dual eligibles. Of these 52 million people, 7 million of them are duals. But 40% of our spending in Medicaid is on dual eligibles. It's a crazy system where our two federal programs can't even work together in a way to maximize the use of our resources. And so hopefully we can talk a little bit about some short-term and long-term opportunities to improve quality of care and to better coordinate with the dual eligibles in Medicare. So we have key challenges in this program. You heard earlier about the racial and ethnic disparities in Medicaid and the 80-20. That's the opportunity that I see in that 20% of our folks are driving 80% of the cost. And so how do we improve that care? And we can do that because right now, let's just say there's a lot of room for improvement. And we've got increasingly sophisticated players. You see state agencies that are taking pretty aggressive roles that maybe we haven't seen in the past, and we have health plans. A lot of consolidation in the Medicaid health plans, and you can argue whether that's good or bad, but I think certainly you can see that there's an increasing sophistication in the way care is delivered and managed in the Medicaid program. So at the National Association of State Medicaid Director meeting a couple of years ago, Newt Gingrich spoke. It wasn't Newt and Hillary. I think they tried to get both of them, but Newt spoke, and he said part of the problem is when we are approached with challenges, we tend to say, no, we can't do this because. And he suggested that we should all change our way of thinking and say, yes, we can do this if. And so this slide is in tribute to the yes-if way of thinking and saying, how do we make Medicaid an opportunity? And in my way of looking at it, you make Medicaid an opportunity if you look at managing care versus managing costs. And we've got to start thinking about what are the opportunity costs of poor policy decisions. How are things that we might be forced to do in the short term actually going to drive costs in the long term? And lots of those are happening. They're happening in states all over the country. They're happening in Missouri. They happened in Indiana. And so the question is, how do you balance those pressures to cut costs in a 12-month budget cycle, yet still be able to invest in an infrastructure in your state that's going to allow you to ever get control of this program? We are working where I am now. The Center for Healthcare Strategies is a health policy think tank, primarily funded by the Robert Wood Johnson Foundation. And it's a great place to be. I get to wake up every morning worrying about quality, and I don't have to worry about getting sued. So it's everything I loved about being a Medicaid director without some of the other things. But we're working closely with states and health plans to make the case for quality. And when we think about that, we're trying to show not only the business case to show the quality pays, but we're talking about the economic case. So when Medicaid invests in a quality improvement initiative for someone that has congestive heart failure who's also on Medicare, and we keep that person out of the hospital, Medicaid doesn't get to count those savings. That goes to Medicare. So it helps that, it's a great economic case for investing in quality, but how are we getting the incentives aligned to reward Medicaid for doing that? And then the social case is one that we started to try to build in Indiana that is of particular importance to the legislators, trying to show that by investing in a child with asthma, we not only improve the Medicaid expenditures, but we keep the child in school, better prepared to learn. We keep mom at work,
she's not missing work to take her child to the ER, but quantifying that and trying to look at the whole picture is really hard. But we're starting to make progress in doing that, and that's how we've got to look at things. Medicaid is one piece of a big system, one piece of a big healthcare system, but one piece of a big social system. And so how do we get smarter about looking at how we're investing our dollars and supporting, trying to get people to support our investments in quality? This is what I call the 5 steps that Medicaid directors go through when, at least for me, I got the job, and I think 3 days later I got the call, and it was cut $250 million this year. And so it's kind of like, well, you start with step 1, cut rates, then you go, that's not enough, so you go to step 2 and you start looking at services, and then you're still not getting your targets, and you start looking at eligibility groups, and then you kind of go into step 4, which is mass pandemonium, and then you realize you want to go to step 5, and step 5 is quality, and step 5 is saying let's go after the factors that are driving costs in the program. And what are those factors? Utilization, whether it's under or over, either way, and the health status of the people that we're serving. And so if we're going to stop the double-digit rates of growth, we've got to go after those factors. And we've got to do the things that are going to provide long-term sustainability. Now, how do you do that and still get your $250 million when you need to get it? There are certainly choices I think we can make that mitigate the long-term impact on some of the quality initiatives. And hopefully, I mean, we'd like to work with states to launch them all the way from 0 to 5 and skip the rest. But if we can't skip the rest, how do we do the least harm when we're trying to build a system that I think we would all agree needs to be rebuilt from where it is today? So why is this so important, and why, again, why is it an opportunity? This is nothing new to you. 80% of our resources are spent on people with chronic conditions. 39%, and that number is growing rapidly, have one or more chronic conditions, and the percentage of people with chronic conditions that rely on Medicaid is staggering. So let's talk a little bit about managing care and Medicaid. What do we want to do here? Obviously, the key is creating a medical home. And by medical home, I don't mean that it has to be, I don't care what the medical home is. It can be on the physical health side, the behavioral health side. The point is that the consumer has a connection somewhere in the healthcare system, and someone is paying attention to what's going on. So we have a medical home that provides the structure for coordinating the care. We want to improve health outcomes and control cost. States across the nation, they use a variety of models to do that. There's primary care case management. We've seen an evolution into enhanced primary care case management with disease and care management that we'll talk about today, full risk managed care, and some Medicaid, Medicare integration demos. I think in Missouri, you're full risk and fee-for-service still. Is that right? George? Is George here? Yes? Yes. Okay. No PCCM? Okay, so I'm going to just, again, talk just a little bit about some trends that we're seeing. And the importance of this is just to say that there has to be some sort of system in place for creating that medical home to manage and coordinate the care. In a fee-for-service system, it's really hard to manage someone's care if there's not some entity or some care team accountable for what's going on with that consumer. And so it's interesting to watch the trends in care management. And when I use the term care management, that doesn't mean it has to be a full risk HMO arrangement. Care management can be the primary care case management or the full risk arrangement. The point is it's not fee-for-service. There's some coordination in the system. So you can see trending up in terms of number of states that are using one of those forms of care management. So today, as of the latest survey, there's only 3 states that don't put their members into some kind of organized system. We also see, not only do you see an increase in the number of states using these models, you see an increase in the number of states putting more critical populations into some sort of care managed system. Again, whether it's primary care case management or full risk. And this just goes through and says, yes, somewhere between 65 and 75% of elderly and SSI individuals, both adults and children, are in some form of managed care. So let's talk specifically about disease and care management. Depending on who you ask, I saw a new statistic last night that said 42 states have a disease management program in place. The point is it's on the rise, and those that don't have it have RFPs out right now, as I know Missouri does, and there's huge interest in this state. Some states are contracting with commercial vendors to do that. Other states are putting it together in-house. There's been considerable innovation in the federally qualified health center and community health center systems, and I caught a little bit of the discussion today. I think I heard that you all have 13 health centers that are participating in the Health Disparities Collaborative. That's phenomenal. They've made tremendous progress in this area. I think that we've all learned quite a bit from their innovation. And then there's a lot of talk about how are we going to address the comorbidities of this population. Disease management and Medicaid grew up with a very single disease silo focused. And the question now is, how are we going to look at the person as a whole instead of the person as a combination of all of their individual conditions? And so there's some work being done to look at clinical clusters, which is basically looking at the most common patterns of comorbidities in a Medicaid population. So one of the clusters that we're looking at is cardiovascular, diabetes, and depression. Another cluster we're looking at is chronic pain, substance abuse, and mental illness. So how do we start to break down the complexities of dealing with comorbidities into manageable chunks and saying, for example, if we're using the chronic care model, what changes in the care sequencing or in the prioritization of care when you have someone that has multiple chronic conditions? And again, Medicaid is a huge opportunity for how to do that better because so many of our members do have comorbidities. So states have options in doing disease management. They can buy it, make it, or I use the term assemble to describe what we did in Indiana, and we'll talk about each of those. There are a couple of other versions of things going on in Medicaid. There are a couple of states that have pharmaceutical-funded programs that are doing disease management for them, and then there are a couple of states that have done something like you all started out with some of the pharmacy-based work. But primarily, you see states that are doing the make or buy, and so I thought I'd spend just a couple of minutes talking about each of those. As of the latest numbers I saw, there are 11 states that are contracting with a commercial disease management vendor right now, again, with many, many more RFPs in the works, so that number is likely to increase. Just to give you a little bit of context of my experience in this, when I took the job for Medicaid director, there had been a legislative mandate passed that Indiana had to contract with a disease management vendor for asthma, diabetes, and congestive heart failure. So I kind of inherited that, and we put out an RFP, and I will spare you all the details, except to say after about 11 and a half months, we pulled that back, went back to the legislature, and talked to them to get the legislation amended so that we didn't have to go the commercial disease management route. And that was in large part, we were fortunate to go to the National Governors Association Chronic Disease Policy Academy and meet Ed Wagner and learn about the chronic care model. And I was there with the Department of Health, and the Health Commissioner in Indiana was a strong partner for us. He gave Medicaid the credibility that I would never have with the provider community. And we decided that we thought it would be better for the state if we put together a model that built on our public health infrastructure so that it was something that was sustainable. We did not want to be dependent on an outside entity coming in and selling us these services. So my experience with this is just, this slide just represents 11 and a half months of negotiating with a commercial disease management vendor. So the advantages are one-stop shopping. You have guaranteed savings depending on who you ask. Some of the challenges, it's difficult to negotiate risk for a Medicaid population. And this is a different population than a commercial population, and some of the same techniques may need a little tweaking. From our perspective, this was a time in the political climate where it was not a good thing to send jobs and money out of state to out-of-state contractors, and those were our options if we were to do the commercial route. The focus of the companies with whom we were talking was very much telephonic-based, and we wanted to have some more interaction with the members. And there was little or no opportunity for our providers to provide input. And one of the challenges I was facing is going and talking to provider groups that we wanted to do disease management, and they wanted to know why would we be paying money to do disease management when our rates to them were so low. And so if we were going to put a program like this in place, they needed to be involved from day one, and we didn't see that opportunity on that side. And there are difficulties interacting with the claim system. So this is not to say that the make or buy model or make assemble model doesn't have challenges as well. From our perspective, the advantages, it allowed for local input and experience. It really focused on the provider and the patient as opposed to focus on the savings reconciliation at the end of 12 months. It keeps the revenues and jobs in state. But most importantly, what we were looking for, Indiana has a very underfunded public health infrastructure. And so if we were going to be spending this much money, why wouldn't we put those resources in our state infrastructure and try to put together a system and a structure that supports changing the way care is delivered across the payer populations, not just within Medicaid. And we thought the best way to do that was to invest resources in the local infrastructure and try to bring that up. Now, these are the challenges, though. It took significant state resources. The state had no one to pass the risk off on, and it took some time. But once you figure out what you want, I mean, either one of them take a little bit of time, but you know, it's not to say that this approach doesn't have its own set of challenges. For Indiana, it was the right way for us to go at that time. So I'm going to talk to you a little bit about the assemble approach that we took. These were the objectives. I'm sure that they're the same types of objectives that all of you have. You want high quality care. You want it at a decent cost. We want to support our providers. For us, again, the fourth bullet point was key. We wanted to use and strengthen the local public health infrastructure. And lastly, we really did not want this to be a Medicaid program. We wanted it to be a program that changed the way care is delivered regardless of your payer, regardless of your disease state, regardless of your location, and really thought that investing in the public health infrastructure was the way to do that. The key principles, I'm going to sound like a broken record, but comprehensive, sustainable, community-based infrastructure, connecting care management and primary care. It was really important to us, again, to solidify that relationship with the medical home, and supporting chronic care for all patients, all providers, all disease states, regardless of the particular, again, payer or condition. So the main program components, I will just go to this picture and talk about it. The important part of this picture for us are the two boxes in the middle, the patient and the provider. Everything else, and this is built on the chronic care model, and you saw that picture before where you have the different supports and the elements of the chronic care model. But everything about us was how do we give support to the provider and support to the patient so that we improve the way care is delivered and strengthen that relationship with the medical home. So starting on the provider side, when we were at the NGA Academy, I think I mentioned we got to meet Ed Wagner and learned about the chronic care model. And we were fortunate that Ed came and spent several days in our state sitting down with us, helping us figure out how would we implement the chronic care collaboratives for the Medicaid provider community. And so the state sponsored chronic care collaboratives, 3 learning sessions and a congress in 3 different regions of the state. So we had 9 running at any given time. And believe it or not, we had about 25 Medicaid teams come and spend 2 days with us in a windowless basement of our Indiana Government Center and work with us on the chronic care model. It was fantastic. And we spread that across the state. Now, I will be the first to tell you, I don't think we figured out how to get beyond those early adopters and how to get to that next group of 25 that wanted to give up 2 days of practice. But certainly it was started, and it was a good thing for us to do because it gave those providers that support and the learning of the chronic care model that they weren't getting from their other payers. On the left-hand side, for the patient, we did the Stanford self-management training. We worked with patients. All of our patients were expected to have a self-management goal. It didn't mean that it had to be the Surgeon General's thing that I'm going to walk an hour every day when I've never walked before in my life. It could be walking 5 extra steps. It didn't matter what it was that everybody had a set of goals. From the bottom end, the tools that we tried to provide, we stratified our patients into basically 80% and 20%. 20% of the highest risk patients, and those patients were assigned to a nurse care manager. And a nurse care manager was assigned to a provider practice. So we had 2 community-based statewide organizations with whom we contracted. One was the Indiana Minority Health Coalition, which had a very great presence and credibility in the urban part of Indiana. And one was the Indiana Primary Healthcare Association, which represented our federally qualified health centers and community health centers. And they had a strong presence in the rural part of the state. And basically, those nurse care managers were assigned to a practice. And any patients that were high risk that went to that practice received those care management services. And we did it that way because we wanted the nurse to have a relationship with the provider practice and his or her team. And I want to emphasize here, the amount of time that the nurse care manager spent with a patient was 4 to 6 months, and that's it. This was not meant to be a long-term social support program. This was meant to be something, get in, figure out what the key problems are, figure out how we re-engage that patient with their provider and their medical home, and get out. Because if we tried to keep if we made that a permanent long-term relationship, we would have bankrupted the program. And so this really was not about a nurse care manager and a patient relationship. It was about an extension of the medical home and a way to reconnect that person to the medical home. And I don't mean to sound cold about that. It's a very big difference. The patients didn't always like graduating, and the nurses didn't always like graduating the patients, but that's the way it was. So that worked well for us. And then on the right there, we developed a web-based patient data registry. It basically had 3 modules, one for the providers, one for the call center, and one for the nurses. Anybody who touched that patient, if it was me, got to see anything anybody else had done to me or with me. Medicaid dumped all the administrative claims data about me in there, and it was the first time that providers could see where I had gone in the system outside of their particular line of practice. And again, I wish I could tell you that it was a fabulous success. It was more successful for the nurses in the call center than it was for the providers. The providers liked looking at the data that was in there. The providers struggled with putting their own data in there. And obviously, it's the practice data, the lab values, the medical records data that's really going to give you that full picture. And we hadn't figured out how to do that yet. We had started to work with our quality improvement organization because they were out in the provider practices fulfilling some of their obligations. But clearly, that was a big challenge for us. And then I think that we learned that we need not focus so much on this tool, but we need to focus on how to get the data from the provider practices, regardless of what tool they're using, and that we should pay more attention to building interfaces and trying to make sure that there's no duplication of data than worrying about the particular tool. And so that was a good learning for us. And then at the bottom, and I'll share a little bit about this, we partnered from day one with Regenstrief Institute, which is part of the School of Medicine at Indiana University. And they were tremendous. They helped us think through the design of the program and the scripts, and they provided the evaluation for the program. So they made sure that we didn't design it in a way that messed up their ability to evaluate the program. And so we'll talk a little bit about that. It's a two-prong evaluation. We did a randomized controlled trial because we really wanted to isolate all the other noise going on in Medicaid. And then we also did a statewide time series evaluation. So basically, quickly, what were we doing? We were doing diabetes, congestive heart failure, and asthma. Chronic kidney disease has since been added. It was a phased-in program that went statewide. We did statewide dissemination of guidelines. I can't emphasize enough the importance of being full partners with our Department of Health in this effort. The Department of Health created a Chronic Disease Advisory Council, and the Advisory Council represented all the commercial payers in the state, the Provider Association, the Hospital Association, and a couple of other state agencies, and we all came together and split off into a diabetes work group, a congestive heart failure work group, and an asthma work group, and came up with statewide consensus-based guidelines that all of the payers sent out to their providers and endorsed them, that we all want to be using the same set of guidelines. The second phase that we were doing was coming to common measures. So we were all going to have the same set of measures for diabetics, congestive heart failure, and asthma. And then in a dream world, the final step would have been that we all aligned our reimbursement. We did not get there. But it was great to be able to have a statewide dissemination of guidelines because, as you know, when providers are receiving so much information from all their different payers, Medicaid may or may not be a critical mass for that provider. And so how do we get the providers to want to pay attention to do the things that Medicaid is doing? At least in our state, we weren't always the most popular payer. So talk a little bit about measurement and evaluation. The teams that went through the chronic care collaboratives reported to us monthly. And then, again, we had the evaluation by Regenstrief. So just about a month ago, Regenstrief released the preliminary results of the evaluation. And basically what we found was a cost savings in congestive heart failure, statistically significant cost savings. It was, when you net out the cost of the intervention, the savings was about $720 per member per month. That's for our congestive heart failure. So that represented about $36 million for the folks that were enrolled in the program. And I told you at the beginning, I disclosed my biases. So of course, I'm very, very supportive of this program. But we believe those savings are real because this was a randomized controlled trial, the first one done in a Medicaid program. So it gets rid of a lot of the noise and the biases that at least CBO and others have come out in their reports when they say that you can't find any evidence of success. Now, diabetes costs money. We found an increased cost in the high risk, decreased cost in the lower risk. I don't think that that's a surprise. I think we would have been concerned if we had seen a huge cost saving in diabetes in the short run because there's a lot of people that weren't receiving the care that they needed. And so net-net, when you net out the cost increase for diabetes and the savings for congestive heart failure, it saved Indiana about $29 million on an annual basis. And so that was something that there was some question, I think, about whether to continue the program, and this gave a good sign that it's probably worth continuing. Obviously, learning as we go. One of the biggest things that changed, and this really points to the need to let these things mature, the cost of operating the program dropped from like $160 per member per month to under $40. And that's because it took so much time for us to ramp up and roll out and get the nurses at capacity and get everything humming that the cost per person was so expensive in the first year, we would have never recognized the savings. But the longer the program is able to be in place, obviously you're going to start to see the return on your investment. And it's interesting, you look at other states, Washington State has spent several years, they have contracted their program out to McKesson. And if you look at their results, in the first year, They did not meet their savings targets, and there was a guaranteed savings component in place there, so McKesson, the state, was basically held harmless. In the second year, they're about this far away from meeting their savings target, and in the third year, I think they believe that they're going to exceed their target. But again, it shows that we've got to be realistic about the expectations we set for these programs to provide cost savings. The Indiana legislators were great. They, when I first started, I would say to them, you know, you're going to have to give this a little bit of time. It's not going to show results overnight. And they would say, well, how long? 4 months? And by the time I left, I had them accepting of that it would take at least 12 to 18 months for congestive heart failure, and it would take maybe 18 to 24 months to start to see some movement in diabetes. And they were, I have to say, in addition to having a great partnership with the Department of Health, our legislators were very supportive. And I think it's because they were involved in the beginning. They were part of our NGA Policy Academy team, and so it was great to be able to go to them. Now, I won't say that means they ever fully funded my budget, but at the same time, they were supportive of having us cut, but not making us cut this program. So kind of a mixed message, but nevertheless, their support was really, really important to this program. As far as clinical measures, this is self-reported data, and the Regan-Streif evaluation does have some more validated data. Basically, though, of the teams, the provider teams that participated in our first round of collaboratives, those are some of the measures that they reported. You can see improvement in hemoglobin A1C, self-management goals, and slight trending up in the better management of the blood pressure. So what did we learn, and what are the challenges? Provider buy-in was a big challenge. I mean, we had not, and I don't think they have since I've left, raised provider rates since 1994, I think, and so not a challenging environment. The incentives, getting the incentives in line was interesting. At the same time that we were doing disease management, we were moving a lot of kids into managed care. And so how did we work with our managed care organizations to make sure that the kids in the fully capitated program were getting the same set of services as not? And how did we convince the managed care organizations that if they improved healthcare status, we weren't going to cut their capitation rates, but we were instead going to allow them to invest in high-risk OB or something like that? So getting all of that figured out. Data is a huge challenge. I mean, really getting your hands on good data. Part of the reason that it's been so successful to partner with the Regan-Streif Institute is because they have an electronic medical record. They provide the majority of care to Medicaid consumers in Indianapolis, so they were able to do that randomized controlled trial because they could wrap the medical values around the Medicaid administrative data and really get a true picture of what's going on, but that's a challenge. Cost savings we've talked about. The MMA is a huge challenge, and what's going to happen to the dual eligibles in Missouri when your state loses access to their pharmacy data? How does that negatively impact your ability to manage care? It's tremendous. And so states are trying different things to figure out how do we continue to receive that information that we need, because obviously you're still responsible for the rest of their care. And so MMA, while an opportunity, in some ways presents also a challenge. For us, our critical success factors, I think that I have already hit most of those. So going back to where we started, I don't feel like I can do a good job for you unless I say a little bit about some of the possible solutions in the short term and the long term, and maybe what we're seeing in some of the other states. But as far as some short-term opportunities, I mean, we've talked a little bit about managing comorbidities. This is a patient population with a high prevalence of comorbidities. You know that. So all of our solutions have got to figure out how we turn that to our advantage. And I would say we turn that to our advantage because the health status has so much room for improvement today. And so the opportunity to improve the quality, which will drive down the cost, or at least maintain or slow your rate of growth, should be seen as a success. Consumer self-management, there's a lot of discussion over this. I think if I asked 10 of you, you would all give me a different definition of what consumer direction or consumer self-management means. Bottom line, in terms of the way I think of it for chronic care, is if the patient isn't in the middle of this and helping you figure out what's important and what the priorities are and who they want involved, then we're not going to succeed. And you know, a lot of people will look at me and they'll say, you can't do that with a Medicaid population. And you absolutely can. And it has to do with having the right care team in place and being culturally competent and being sensitive to the literacy levels and figuring out what that person trusts in the healthcare system. But it is no, I would argue you can probably do it better in a Medicaid population than you can in many populations if we start to become more sensitive to some of the other factors. Special needs plans, those were created as part of the Medicare Modernization Act. That really is an opportunity for states to work with health plans that will be serving dual eligibles and figure out how to better coordinate their care. Today, there's so much fragmentation between the Medicaid and Medicare system that results in duplication of services and inefficient use of resources. And if we could just capture all of the wasted resources going that the two programs are doing, we could do quite a bit. And that's some of what I'll talk about for the short term. Medicare is, it's interesting to me that when we talk about the healthcare system, and there's always talk about Medicare has a problem and the commercial sector has a problem, and the things we hear about as solutions are investing in quality and health information technology and pay for performance. And when you talk about Medicaid and the fact that Medicaid has a problem, the answers you hear are, well, go cut $10 billion. You know, you don't hear people talking about the very same solutions for Medicaid that we're talking about for the other payer systems. And so really there's an opportunity at the federal level, I think. Secretary Leavitt and Mark McClellan, they're very big supporters of quality and information technology and pay for performance. And we've seen that in the Medicare side of the House. And so being able to bring that into the Medicaid line of thinking, I think, is a huge opportunity. There's a lot of state and federal reform efforts going out around. Florida just got their waiver approved. Vermont has a waiver approved. South Carolina, Georgia, West Virginia, they're all waiting in the wings. I would anticipate we'll see a big domino effect now that one's gotten through. So there's a lot going on, a lot of laboratories of innovation in the states across the nation, just figuring out really what each of those means and how do we take good things from those and allow other states to do those in a more flexible manner. Scorable savings. This is a challenge that we confront when trying to talk about federal reform. You have to show them that there's going to be a positive score. And so you talk to the people at CBO and GAO and you try to get them to think about investing in quality and how that's going to save money and not cost money. And it's just not happening yet. There's a lot of disbelief that investing in quality pays, if you will. And even some of the Medicare chronic care demonstrations where there's a guaranteed savings. So they guarantee that we're going to save money, otherwise the company pays, and CBO still scored it as a cost. So trying to figure out that world is something I don't understand. But others, I think, have started to bang that drum. Again, going back to Newt Gingrich, he had a quote a couple weeks ago in the Wall Street Journal and said, we're never going to get this thing fixed if we don't change the way we think about savings. And looking at health information technology totally as a cost and not recognizing the benefit it can do for the system is absurd. And so, you know, people, I think, on both sides of the aisle are starting to recognize that we've got to change the way we look at things. And then I thought I would spend just a couple of minutes, we good on time, on the Medicaid Commission. The Medicaid Commission, I'm a member of that. I'm serving as an ex-Medicaid director. They had certain spots on the commission. There's 15 voting members. We have basically two charges. One is done. It was to come up with a report to save $10 billion. That was due September 1st. I can't tell you what's going to happen to that report. Some of what was in the report is now in the Senate's budget reconciliation bill. I don't think much, if any of it, is in the House reconciliation bill. It was a necessary exercise, but certainly my interest in serving was to do the second part of the mission, which is to come up with long-term policy recommendations to change the way we think about Medicaid. And that report is due December of next year. And so this group, we just met for the past 2 days and came up with a way of attacking the opportunity going forward. And so essentially, the commission is going to organize its work into 5 modules. One has to do with eligibility, one acute care services, another is long-term care, a 4th is quality and IT, and a 5th is administration, which is kind of a catch-all for fraud and abuse and IGTs and any other acronym you can think of. And basically, over 2006, we're allowed to meet 6 times, and 5 of those 6 meetings will be devoted to attacking each of those areas. And so the goal really is to level set our understanding about each of the topic areas, and then to look at best practices that are going on in those areas and figure out what can we learn from those best practices and how can we put those, what's the right balance, what should we have on a national level, what should be left to the states' autonomy, all those kind of things. Yesterday, there were a couple of presentations. I had the opportunity to talk to them about best practices in disease management. A couple people talked to them about best practices in CHIP, and just highlighted that the S-CHIP program was an example of states having a little bit more flexibility and figuring out how to do their model. Some could do a Medicaid expansion, some could do a state-only program, and what could we learn from the flexibility that was given to states from that experience. And then Tony Rogers from Arizona, I'm not sure if any of you know him, he came and talked about the Arizona program. And Arizona is unique. They figured out, like, from the beginning of Medicaid that they didn't want to do it the way everybody else did. And they've always had a series of waivers, but he brought up some really good points, and a lot of points around flexibility, but the discussion really got to how do we have a set of national standards and a set of national tools, but allow states to get there the way that that is best for their political situation, financial situation, community resource situation. So, in other words, why does every payer have to have a different set of guidelines for disease? So shouldn't somebody with diabetes, don't we all need the same thing? And why does everybody have to pay differently? And why are we wasting resources on all these parts of things? Instead, why don't we focus on the end game? And if our goal is to make people healthier, hold that as the standard, give people the tools, let them choose how to get there, but use the state innovation and state flexibility and state resources, and everybody's system is designed differently. Let you figure out how to get there the best way for you. And so those are easy words to say. It's a little bit more difficult to figure out how you would do that. But certainly I think there is a movement toward having more of a focus on outcomes, which would be a nice thing. I think we talked a lot about, there are big challenges, so I can stand up here and tell you that you need to be investing in quality, and quality pays, and value, getting more value for your dollar, but how do you do that? I mean, in a Medicaid system, the financing is a real barrier. You have to spend $1 to get $1 from the federal government. Well, these things take a lot of dollars to put in place as an upfront investment, and so how do we help states or provider practices or health plans that want to invest in this kind of infrastructure? How do we do that? And there's a couple of different ways that you can think about it. Now, I'm not sure, so I was in front of all these federal people yesterday advocating for additional federal resources, so I'm not sure that was too positive. But for example, when the federal government said, we want to make children's health care a priority, what did they do? They gave an enhanced match rate to the states. That worked really well. States responded to that. We got a lot of kids enrolled. I don't know that we can tell you how much better their health care status is, which is a whole other conversation, but it had the immediate effect. So if chronic disease is what everybody agrees is bankrupting our health care system, why don't we realign the incentives to support states investing in chronic disease? When the feds look at waivers, when states ask for waivers, they look over a 5-year time horizon typically. Maybe we should rethink the way we're looking at chronic disease investments and helping states meet some of those demands on an upfront investment and letting us pay them back as we go. So I think we've got to start thinking creatively about especially health information technology, and I was encouraged to hear Julie's comments on that this morning or at lunch. That's an area where there is great opportunity. There's also great concern that everybody's going to go out and put a lot of money in a fragmented system. But if we're going to be serious about that, states and plans and providers need help with those initial upfront investment costs. And so how do we provide tools like that? And then data. We have tremendous power at our fingertips with the data that we have. How do we use that data more effectively to better use our resources? And then the last area, in addition to looking at financing and data, would be flexibility. And again, how do we work with states to give them the flexibility to run programs more effectively, yet still have a certain end game so that it doesn't matter where you live in this country, you should be getting the same type of care regardless of your payer and regardless of your location. So when we go and do work with states, we're talking to them about building blocks and thinking about what are the core elements that you need to put together an infrastructure that's going to support quality in your state. And I'm not going to go through all of these. I will just say, I don't know if you have copies of this presentation or not, but these list examples. There's a lot of innovation going on out there in Medicaid programs and with Medicaid stakeholders. And these just list some examples. For example, evidence-based practice. It talks about some work done in New York and Indiana to adopt standard evidence-based guidelines. Measures and outcomes. You see a lot of work on report cards. Pay for performance. New York is distributing, they'll distribute close to $27 million this year in financial incentives to their Medicaid providers. Care management. North Carolina is a great model to look at for some of what they've done with their care management and how they've built a really strong infrastructure to support chronic care at the state and local level. Integrated care. These just give examples of the things that are really key to supporting chronic care improvement in a Medicaid population and hopefully beyond, and places where it's happening. And it is happening out there. There's a lot going on that we can all learn from as we try to make sense of this situation. So with that, I think that I would love to take any questions if we have time. Okay.
You guys, we have plenty of time for questions, so please. Well, first of all, thank you, Melanie. That's great.
How do we have so much time left? Oh, okay.
I know that was a lot to take in. to the state for tobacco use?
There was some work done on that, not within the Medicaid agency. There was a separate tobacco and prevention control agency that attempted to look at that. But it was not something that we did in the Medicaid agency. The question was, what kind of provider incentives did you come up with and how many people were enrolled? The provider incentives, we considered the nurse care managers to be an incentive to the providers, and giving them that extra set of hands. That the electronic patient data registry was something that was provided free of charge, and we provided a call center and help desk and all that stuff. The only thing that we had tried to change reimbursement, at one of the chronic care collaboratives, I asked the providers what most frustrated them about our reimbursement system, and they said that we wouldn't reimburse for non-provider group visits. And so we set that code up to start reimbursing for that so that we would pay for the consumer self-management and all those kinds of things. In the 18 months it was up and running before I left, we hadn't been billed a single time for it. So I actually would go around the state and beg people to bill us for that code. It didn't work. I'm not sure what the barrier was. We got it down to like a half-a-page sheet. Here's what it is. It was pretty flexible, very open-ended, and no one was using it. So it obviously wasn't effective. Something went wrong. But that was the first step we had taken to try to change the reimbursement. Oh, and as far as the number of people enrolled, when the program first started, diabetes, congestive heart failure, and asthma were all in the program. And there were probably 65,000 people eligible at that time. Now it took some time to ramp up. Then we moved a lot of the kids into a managed care program, so that took about 40,000 out. So in the program that's left, that's not with a managed care organization, there's probably 27,000 people with diabetes or congestive heart failure or both. I will say the advantage, and I know you talked about the chronic care model earlier, advantage for us in using the chronic care model was it gave people a framework on how to think about improving quality of care regardless of the disease state. And so as the program went on, we integrated depression screening, and we're able to do that in the model because the model was there and it wasn't disease specific. And so as the priorities and the conditions changed, the infrastructure was there to support thinking about how to deliver care differently regardless of what the particular clinical focus of that time was, which is really important for the comorbidities. But the depression screener was a very positive step that we were able to take and found, just like everybody else tells you, we found about 40% prevalence in the population.
Thank you again for being here, and you give us a lot to think about. I have a question sort of at a broader, federal level. The Medicaid Commission that you're working on now has put out a preliminary report and is about to put out a longer report later on. The National Government Association has put out its report and recommendations on Medicaid. I understand the administration has its own plan on Medicaid. How are we going to reconcile all those, or are they going to be reconciled? And who's going to step up and take the lead and make some real changes occur? Or maybe it's going to be at the state. So just what's your thoughts?
I heard it was going to happen in Missouri. You're charging the hill. Great question. The question is, you got all these different groups out there putting Medicaid reform proposals in place. Are they going to come together? Who's going to take the lead? What's going on there? The commission actually used the NGA's plan as the starting point. And pretty much all of the recommendations that are in the Medicaid Commission's $10 billion plan mirror what was in NGA. Now, NGA had some that went further than what the commission adopted. But there was pretty good consistency with the NGA and the Medicaid Commission. Not so much the same with the administration's proposal. There differences, particularly in the area of pharmacy and in the area of some of the eligibility changes. I would guess going forward the commission will be more aligned with NGA, and I can't speculate on where the administration will be. And then, you know, the Senate and House are completely at opposite ends in terms of what they want to look at. So I think it's a great question. It is a huge problem because the collective brain power being spent on this would be much better spent if we were all channeling it together. I mean, I'll be the first to tell you, I think there's a lot of question about whether this commission is going to be taken seriously. And any given day, a different entity is boycotting it. So I just go and wake up every day totally naive and just hope for the best. Because I just, you know, you got to try it. We've got to try to think about injecting quality and value and effectiveness and long-term thinking as part of the solution. But I can't. I wish I could tell you. Maybe you should be the ones to storm the hill. I think it depends on how it's designed. It certainly could do that if the results and the outcomes are not risk adjusted to take into account the complexity of the patient population. I would say that the more sophisticated pay-for-performance arrangements that I'm aware of do risk adjust, so they take that into account. But certainly those that don't do penalize. It does harm providers who have a sicker population if they're not risk adjusted. Sure. Just to repeat the question really was, Medicaid is a conglomeration of a bunch of different types of groups: kids, healthy adults, people with disabilities, people in institutions, seniors. So the question of how does the model work for all those folks, I think, is your question. And then how do you address the comorbidities, especially some of the behavioral health issues? The chronic care model actually, and again, I'm a believer in the model, but I believe it works for all populations. I mean, it's putting together a system and an infrastructure that supports delivering care a certain way, regardless of the population and regardless of the conditions. Now, certainly some populations are more complex than others, and I think that's where it's really important that your call center is linguistically competent. You have interpreters available. Your care managers are culturally sensitive. They're part of the community. They understand those different factors. We didn't find as much of a challenge in dealing with the different populations, but I will say it was actually the hardest population for us in this model were the kids with asthma, and that was because you had to get their parents convinced, and the parents didn't want to feel like they weren't doing something appropriate for their child. And so it's actually harder for us to go through the parents to get to the children with asthma. And I know in asthma, too, it was really interesting. A couple of times we had experiences where the nurse care manager would be graduating the child because the child had done well and had improved. And the next day, the mom would take the child to the ER, scared to death that meant that their eligibility was going to be gone. And so, how do we reorient? So I guess the short answer the long answer to your question is we did not find it to be challenging across populations. Though Indiana did not implement this program for folks on the waiver or in institutions, although dual eligibles were in the program. The second question about how you integrate it, you're absolutely right. I mean, it is, as all systems are, built on kind of the disease state is your ticket into the program, and you get identified somehow, typically by a single condition. And the depression screening that we had started to do was effective, but it wasn't fully closing the loop because we hadn't figured out the right way to bring the primary care provider back in. I'd say one of the things that we got smarter about was just making sure that we were more flexible about who a primary care provider was and encouraging behavioral health providers to serve that role, and that seemed to make some difference, but we didn't get that figured out. We were just trying to figure out how do you take the change concepts in the chronic care model and incorporate the behavioral health element into that so that we were responsive to the comorbidities. But it's an evolution, and it wasn't fully figured out. Oh, I do have one more thing. I just remembered. We actually were more successful. We see more success on that in the federally qualified health centers, who are able, because of their wraparound cost-based funding, to use the funding a little bit more creatively and do some of the physical health, behavioral health integration, and pay for that more creatively than in some other locations. But I would say that would be the area where we had the most success.
I just wanted to ask, how did the financing work with this project? How were the providers paid? Did they pay fee for service or on a capitated basis?
These are, this was just part of the primary care case management program where the providers were getting fee for service plus a $4 per month case management fee.
And then the call centers and the nurse care managers, were they out of the same offices and clinics as the primary care providers, or
The call center was a centralized, yeah, the call center was a centralized call center we actually added this into the existing Medicaid call center. So because they were already familiar with the providers and the recipients and all of that, so this was an incremental addition to that, and that was an off-site location. The nurses, we had the 2 statewide organizations, and they split up the counties, and they were assigned to provider offices. Some of them were co-located at a particular provider's offices. Some of them rotated depending on the volume of patients at each of those practices. Does that answer your question?
had those nurses previously worked for those same care providers? And you said that
Some of them had. I mean, that was the beauty of contracting with existing organizations that were already community resources and they had community credibility. Some of them had been. I would say though that we had more of them that had been in hospitals in their communities as opposed to the provider practices, but they already had established relationships, which was really helpful. One of the things we learned a lot about the nurse care manager, we completely underestimated the differences in the rural and the urban caseloads. So we had a one-size-fits-all caseload until we learned just the differences in the time spent just driving. And so we had to make a lot of modifications on that. I'd say the other lesson learned for us, we had in one of our organizations, nurse care manager organizations, tremendous turnover, over 100% turnover in the first 3 to 4 months, and it really set the program back. We had just gotten patients to almost that 4-month mark and then literally basically lost all the nurses and had to start over. And that was a really expensive, good, but expensive lesson to learn, but it had a ripple effect on the rest of the program. We couldn't touch people as quickly. It cost more. It took longer to ramp up. All of those things played into that. And that was something, I mean, we just didn't think about it, had no idea we'd expect that. The nurses had a caseload of between 125 and 150, and that was at different phases. So we had what we called sort of the intervention phase and the reinforcement phase that went over that 4 to 6 month period. So they were not in the high intense beginning for 125 people that was phased over time. But it took a very long time to get even close to that caseload. Would I comment on spin down? I suppose I have to be polite in my comments. Indiana is a 209B state. Are you a 209B state? No? Yes? I can't see George. Spend down was a huge problem. And we tried to go to the feds to say, obviously, if spend down has had a huge number of people that would be eligible for the program, but trying to figure out how to do that. So we had tried to do it so that they could pay in at the beginning of the month, and then as they met their spend down, it worked. It was like a premium. We got turned down for that, and so spend down was a huge problem. Another frustration sort of related to that, on the kids, as a cost containment measure, Indiana eliminated continuous eligibility. So we had 12-month lock-in for the kids. Well, we eliminated that to save money, but then we had all these kids in the asthma program, and sure enough, we would get pretty far along with them in the intervention, and then they'd lose their eligibility. They'd come back in 3 months, but we had to start them all over, and so we wanted to go to the feds to just lock in the kids with asthma for a 12-month period, and we're not allowed to do that because we had to lock in everybody if we were going to do that. So those are examples, I think, where we could be smarter about the federal policy flexibility for states. I mean, we could show the feds that it was costing us money to do that, and it didn't matter. So I'm not blaming them. I mean, we had a part in that. We cut the eligibility, but actually could tell that it cost us money. So anyway, duals at 209 spend down, big problem for us. question was, does Indiana have consumer-directed care and allow family members to get paid for providing care? The short answer is no. There's a little bit of it in some personal care services, but we don't have a fiscal intermediary or anything that's allowing the consumers to actually take the dollars and direct them toward their caregivers. Or we didn't when I was there.
Pharmaceuticals, have you, what's your read on how that will play out and how chronic care programs are supposed to deal with that?
The question was about dual eligibles and the impact of on their pharmaceuticals when it switches to Medicare. We have been working with the feds to allow states to continue to get access to that data, and the latest information, my understanding is the feds are trying to develop a common data file format and a common data sharing agreement that would allow prescription drug plans and states to do a data exchange that would pass, the HIPAA muster. And we're trying to support that and figure out, when I say we, it's the Center for Healthcare Strategies, have 2 pilot programs going with 2 states to try to facilitate that hopefully then could be a model for the other states. I think the problem is obviously in the short term, and we're about to approach January 1, and we're going to have all these people that have to go through new fail first and new step therapies, and we can't seem to figure out a way to get the data to the plans before January 1st because it violates HIPAA. Because if the person is auto-assigned and hasn't actively enrolled with that plan, then that plan isn't a business associate or we don't have any way of legitimizing the data exchange. And so short of getting consents from all of the dual eligibles, which is unlikely, we have been talking to a couple of plans in a couple of states about could we de-identify the data for the dual, could the plan send us their list of auto-assigned people? Could the state look at that on a de-identified basis and give it back to the plan, and so that at least you can see where the big gaps are going to be? And then as soon as the person says, yes, I want to be in that plan, send it to the plan on an identified basis. But it's a very cumbersome process. I think what's going to happen in those couple of states is we're likely to try to figure out how to identify the most at-risk duals and just try to focus on that subset and see if there's something that can be done to ease the transition since it's getting so close. So I don't have a good solution. I know a lot of things that people are trying, but not anything that's worked yet. Is that it? Thank you very much.
We're going to take our last break, and we're going to meet back here at 2:30 for the final panel.